Yeah, hi and welcome. I'm interviewing today Rory Murray. Rory is the head of Medical Services of Bristol Rugby, and he has an interest in groin injuries, which is quite a hot topic, obviously, in sport. And I wanted to get his tips for this subject. Hi, Rory.
Hi, Marcus. Thanks for having me on.
Do you mind telling us a little bit about you, how you got there, and what your interests are?
So I am a physio by trade, and my background is in, well, probably elite sport in Ireland, where Gaelic football was my #1 sport, which probably specifically spawned my interest in groin injury, because that's among our biggest time loss injury. Obviously, the twisting, for those that aren't aware of what Gaelic football is, it's very similar to Aussie rules, lots of kicking, twisting, turning, and the pitch is much bigger than a soccer or a rugby pitch, so there's quite a bit of running as well. And groin pain and persistent groin pain is a problem. And it's really from Gaelic football, qualifying as a physio, merging into, well, rugby is probably our main professional sport in Ireland, and particularly where I'm from, Ulster is the only professional team, Ulster Rugby, and I worked for them for 4 years before moving across to Bristol, where I've been for 10 years. And probably through that time, and certainly pertaining to groin injury, it's not, groin injury is far from the first injury you would think of when you think of rugby union, but we do tend to find when it sets in, it can be pretty stubborn, and it's kind of spawned a bit of an interest in itself.
Yeah. Can you tell us in rugby how common it is and what you encounter there?
I think when you mindful that not everybody listening would be an avid rugby fan, it's important to distinguish between two very dichotomous positions or positional unit types in rugby. We have forwards and backs, and they're very different shapes and sizes with very different game tasks and running metrics. So within forwards, it's about 2 per 1,000 hours. The forwards are much heavier. The running is very linear. There's absolutely no kicking, very, very little twisting and turning. Rugby union backs look a little more like soccer players, obviously a little taller, maybe a little heavier, average weight about 100 kilos, so maybe a bit bigger. Their groin injury rates right up there, 3.1 per 1,000 meters. That's the recent epidemiology, and that actually is quite close to Aussie rules and quite close to Gaelic. In terms of kicking, quite a few of the backs would engage in kicking, but not all of them. Still a lot of twisting and turning, although a very linear sport, backs would cover a lot more distance than forwards and at a lot higher speeds. So whilst, like I say, it's not the first injury you would think of with rugby union, when you extrapolate that to backs only, it can be quite a problem. And probably, whilst maybe more anecdotal in terms of the injury data that I've captured from my 4 years at Ulster, 10 years at Bristol, is that with backs, it can be a little bit more severe, whereby our average severity for groin pain with our backs is 40 days, where it's right down at 6 days. So when you really want to mine down to how big a problem groin injuries or groin pain is in rugby, frequency gets it a little bit, severity is probably where it's a bigger problem.
And what do you see most commonly?
Well, I think with regards, I think we see a commonality in why it happens. And now I'm probably speaking exclusively about rugby union backs, because rugby union players are globally quite strong. I'll probably circle back to that towards the end, but rugby union players are globally quite strong. Weight training is a very big part of their week, maybe over and above running. And so you're dealing with a trained population, a very trained population, but with a common, I guess, onset of injury. So we see, like you would see in any other sport, acute and chronic types. With regards how we acutely get groin pains, it's much like how you would get it in judo, where you're getting this forced lengthening, particularly of the adductor longus. So what we tend to see with our acute groins, when they go big. And so we see, to use the BAMIC muscle injury classification scale, we would see sort of grade 2 to 3, often C injuries, where you're getting tendon failure at the bone enthesis or high-grade musculotendinous tears of the adductor longus, almost exclusively the adductor longus. And it's from a particular contact mechanism where a player is forced into the splits quickly, usually under the weight of another player, or their leg is forcibly abducted away. And that's almost always how we get it acutely. There would be nothing in kicking that would do this. Like I say, often there's only 1 or 2 players in the team that kick, and they're often so well conditioned to do so, and they do it at much less frequency than soccer players. That's rarely going to do it. It's where the chronic pain comes in. And with the chronic guys, we'll still get inguinal hernias, particularly problematic are the tug lesions where you'll see like a cleft sign on MRI, something we'll discuss probably later. And occasionally we'll see some osteitis pubis types as well in the chronic types.
And you also said you have some hip problems, but I guess they are also more chronic and not too acute things, so is it?
Yeah. So classically what you would see with sportsmen with regards hip pathology, you'll often see some misshapen heads of femur. So you'll see some pincer or cam deformities. You'll often see that. Obviously, you'll see that in there. Typically, we're just internal rotation where you're getting that early hit. But often what can happen, particularly with our guys, is the late sign for that can often be some pubic synthysis irritation where the lack of internal rotation available forces the pubic synthysis to migrate downwards or migrate against the other side. So yeah, we do see hip pathology. I would say it's rare that we're having to repair hip labrums. But yeah, in chronic groin pain sufferers, you'll often see a misshapen femoral head or some kind of pathology in the labrum.
When we come to diagnostic tools, obviously you've got the history, and then obviously from the history you choose your diagnostics. But is there anything particularly you would say you stress you do mostly in these kind of problems? I
think we're often, with regards to the pathologies we see, across the 14 years that I've been working. So that's just like it's all my data collection. You're really only seeing 5 different types of diagnosis. So you're not seeing a large plethora of ones. So you're often seeing common pictures. Aside from your typical clinical tests, plain film MRI or MRIs are our first port of call. We've never used MRA, and particularly in acute injury, we've never had to use MRA because blood is there, and we don't feel that it's needed. So plain film MRI is a good place to start. And if we do see, and probably more towards the chronic signs of groin pain, often they'll do nerve block, particularly of the ilioinguinal nerve, as an assessment to see is that involved. That's obviously a guided nerve block. That's been quite helpful as well as probably quite therapeutic. But we always start with MRI. Rarely do we ultrasound these. Okay, so ultrasound is basically second line. Do you use it at all, ultrasound, or how would you go with somebody who you're looking for maybe a inguinal hernia, which is not too obvious on examination? Yeah, I think then also we've got to sort of think environmentally. So I'm in a professional rugby club, but it's not as well funded as what soccer is. We do have some immensely talented doctors here, but often with other roles, so they're not full time. If we feel ultrasound would be a useful diagnostic tool, definitely we'll do that. But it may be that the doctor's not on hand to do that. We don't have, and even they're probably quite general sports medicine doctors as opposed to radiologists in themselves. But we wouldn't rule it out. But just as a first protocol, we'd probably start with MRI and then open that up. Okay, thank you. Then I think we come to the quite a big point for you is obviously how you treat those, yeah. And obviously you've got your definitions of the injuries you have, and would be great to hear. You told me that you have your own rehab pathway which you developed, which has been quite successful. I'm quite interested in this, and if you wouldn't mind to explain it to us. Yeah, I think probably the rehab pathway. So we've all got a decision to make, and this isn't unique to groin injury or unique to rugby. Do we proceed surgically or conservatively? I would say if we do make the decision to move surgically with an acute or chronic groin problem, I often find, because the nature of the rehab that I'm doing, I prefer to front load with some conservative rehab anyway, for the simple reason being, and we'll come to what I try to intervene with, try to learn some of the movements or relearn some of the movements in the presence of stitching or pain is not a great environment to do that. So often, even if surgery is decided as a treatment tool, we'll do a little bit of rehab to start with just to learn some of the movements. But it's probably in the conservative management that we really see what I'm trying to get after here. And pertaining to rugby particularly, we'll see a particular type. We'll see somebody in big anterior tilt with big rib flare, prominent rectus abdominis, and a large pelvic tilt. And we'll see that across all of them. So rugby players are well muscled, well trained, but they'll often carry themselves in that forward tilt. Of course, if you're in that forward tilt, so if you're in anterior tilt, particularly end anterior tilt, you're in relative hip internal rotation. So to your point on hip pathology, we can gain a lot of internal rotation simply by getting the pelvis out of the way. So learning how to move your pelvis, how to, posturally, I don't mind if you walk around in anterior tilt, it's your ability to get out of that. If we can posturalize the pelvis, will enable more rotation, particularly internal rotation of the hip. The other big thing, particularly, and this is where we see it with rugby union backs, is that when we are stuck in anterior tilt and unable to get out of that, the adductor longus is the primary hip flexor. This probably plays to why one of our more stubborn injuries is that tug lesion, that cleft sign on MRI, where that adductor longus is having to pull the leg through at long lengths meaning the muscle is at its weakest, one of its weakest points. So it's having to pull the heavy limb, the heavy shank through at long lengths, doing a job that's really not supposed to do, and it's acting as the primary hip flexor. So to that end, one of the big things that we do at the start of our rehab process is to learn to move our pelvis. And there's where we talk about sequencing. We sequence proximal to distal. It's that old stroke rehab that you would do as a physio back in uni that we can really bring to the fore here. How do we move? We move near before we move far. So we learn to move out of anterior tilt into posterior tilt, then the leg comes through. So that's a foundational movement. And often that's one of the big drivers in chronic groin pain in rugby, which is fundamentally a linear sport. We move straight up and down a pitch with only probably 2 or 3 people kicking. So those are not the reasons. Twisting, turning, and kicking are probably not the reasons why somebody has that stubborn cleft side or tug lesion. It is generally because they're using their adductor longus incorrectly or overworking the adductor longus as a primary hip flexor. So first thing we do, get out of anterior tilt. And to do that, we use our obliques. It's often not what we do, but how we do it. So you can't get out of anterior tilt simply by clenching your glutes and sitting back on yourself. So you've got to get out of anterior tilt using your obliques. So pelvis through, then leg. What we'll often see in people with groin pain, it was actually my postgraduate dissertation, was does adductor squeeze modify before the onset of groin pain? And it didn't. So that was taken across 2 seasons in professional rugby, and it didn't. What we often see with adductor pain specifically, now probably talking about the chronic population, is that when we test them and they test weak, that may just be pain withdrawal. And often we would say the adductor, almost always talking about the adductor longus here, almost always the adductor is the victim. It's simply overworked rather than being weak in of it itself, and simply facilitating other muscles around it in a facetious way, just kind of allowing it to kind of reset, allows the groin squeeze, or whatever metric you use, the groin strength to come back up. So I think in terms of I use groin squeeze and dynamometry when assessing groin patients. I use the strength outcome very carefully. Is it pain withdrawal or is it genuine weakness? So actually, speaking specifically about the rugby population, training the adductors is something we do last, sometimes not at all. If we feel that the adductors aren't in themselves weak. And this is unique about the rugby population because they are very strong. They are very, very strong men playing a low running game. What we often tend to see, and a big part of the conservative rehab, is we know that the psoas is a primary hip flexor above 90 degrees and when the pelvis is neutral or in posterior tilt. And because if you're walking around in anterior tilt all day, that is a shielded muscle. That's a muscle that's not getting any stimulus. And that muscle is genuinely weak. So if we are going to train the pelvis to posteriorize, to move on out of anterior tilt, to move first, then bring the leg through, then we've got to give the leg the strength to do that. So we do train the psoas specifically above 90 degrees. So we train the psoas. That's a big part of this. So that front side mechanics, now we're getting into our running mechanics. So it's for that reason, particularly with our rehab of groins, that I divide my pathway into a linear pathway and an offline pathway. So I guess the skill in rehab is we know what the destination looks like. Let's say along the linear pathway, along straight line running, we know the end pathway is fast running. So the job of the physio or the rehabilitation specialist is to piece that together to get to that point. The first movement is to just move your pelvis, is to sit and move your pelvis from anterior tilt to posterior tilt. Okay, can we then do that with my rear leg on a TRX? So I'm still not running. Can I have my rear leg behind me? Can I still drag my leg through? Okay, can I do that in slow running? Can I drag my pelvis through, place my leg in front of me? Can I do that a little quicker? And that's how that linear pathway develops, how that proximal to distal sequence develops. In the background of that, probably still not doing any direct adductor training. We're trying to let that settle, especially if it's that cleft sign. We don't want to keep tugging on that. And we're training the psoas. So really the adductor longus is getting very little here. And then if we're training the pelvis to come through, then we've got to train our stance leg to be stable on landing. We see the example, and you would see this in your own clinic, that if somebody came to you with pain at the front of their shoulder, I'm certain that they would be prescribed some external rotator cuff work. Well, similarly in the pelvis, on the stance phase of running, or rather in the hip, in the stance phase, when I put my leg to the ground, I want to see some hip lock. I don't want my pelvis to drop, that Trendelenburg sign. We don't want to do that. Because when doing that, well, you're also pinching your hip again. Therein we could irritate the hip pathology, or we're trapping that tug lesion, or we're tensioning it. So what we want to train is for when your leg lands, our pelvis stays level. So we just, again, that's a different pathway in itself. It's the equivalent of training the rotator cuff, but of the hip. So it's external rotation exercises, anti-Trendelenburg exercises. Can I keep my pelvis level standing on one leg? Can I keep my pelvis level when I'm hopping on one leg? Can I keep my pelvis level when I'm running? And looking at that. So marrying sequencing with hip lock. So one leg is bringing the pelvis through, the other's landing square. Those are the focuses of our linear rehab. And sometimes when you're investing along that line, if you still are getting tugging of the adductor, you would consider surgery. And tenotomy has been very successful for us here. Our go-to with that is Ernst shoulders, and just simply detensioning the adductor longus has given us excellent results with that.
Yeah, it's actually quite an interesting point you make with that they are so strong rugby players. And then, you know, if you think about the first thing you get taught always with groin pain, you need to strengthen your adductors. So there is really a specific difference. Yeah, and I guess you're not using very often than the Copenhagen adductor strength training.
Well, if you're at a point where your adductors squeeze, which probably first and foremost is a pain provocation tool, if that is painless, I think that's a good point that's a good point to assess. If we assess that and we do see that the adductors are in themselves weak, the Copenhagen scale or the Copenhagen protocol, the parahomic stuff, that's great. That's fantastic stuff. You know, doing that at different lengths, at different speeds, that's a big thing. And fundamentally, you know, I think when it comes to rehabilitation, you've always got three options, speaking conservatively. One is that you move so well that strength's not such an issue, that muscles are never working at very long lengths. They're never under tension for too long. You're just moving beautifully. So that's plan A. Plan B is that you're so strong that how you move doesn't matter, because injury happens when load exceeds capacity. So if I make my capacity so big, the load can never get me. In reality, we always do a little bit of C, which is a bit of both. We try and move well and add strength. But I think in the beginning, and I think specifically, and what we see a lot with the rugby guys is that tug lesion, chronically that is, that particularly with that tug lesion, I think first and foremost, it's get off the adductor longus. It's clearly tethering. And I think if it becomes painless, that's a great place to start with your Copenhagen's, and they're a great strengthening tool.
Yeah, and you also mentioned surgery. How many of those tuck lesions do you think end up needing surgical interventions?
I think this is something where I've changed my practice probably in the last 5 years. I think particularly back in Ulster, where I started to figure out probably some of the drivers to why these tug lesions were there, and thought that probably naively good conservative management would get us there, only to find that, yeah, they'll get you pain-free and moving well, still maybe aware at those top end speeds, and an athlete coming back still modified, which is always a problem in professional sport. We want the athlete to train fully and integrate fully into the squad, but having somebody that's constantly in and out after a long rehabilitation period can be a hard sell for a coach. And I've probably become more interventionalist with regards to these tug lesions. If we identify one of them on MRI and they become symptomatically or symptomatic and problematic, then I won't hesitate with tenotomy, because ultimately the rehabilitation period will always carry some uncertainty at the back end. But the tenotomies for us, and I think we've probably done 5 in the last 5 years, every one of them has been super successful, certain outcome, back playing in 8 weeks. And I'm aware of the risks, I'll probably take the certainty just because of the environment that I'm in.
So I think you already mentioned the Per protocol, because obviously not all of our listeners will be looking after such strong elite athletes like you will be. As a systematic way of rehabilitating somebody, would you say that could be the first step in a non-elite population?
It's your go-to in the non-elite population. It's perfectly linear. It's easy to follow, low equipment required, and I think that'd be eminently successful at somebody who's operating just below the elite pathway. I think that's a really good rehabilitation tool.
And I think when we speak about your difficult patients, is there any other form of injections you use apart from obviously the recent nerve block of the ilioinguinal nerve you used for diagnostic and treatment purposes? But did you come across any treatments which have been used in this sphere?
Thankfully, we haven't had to go there too much. And like I say, groin pain does not sit top of the pile in terms of our time loss. If you think of our preventable injuries, so our non-contact training injuries, those are the things that you're first trying to get down, I guess. It's always hamstring and calf. Groin would come maybe a distant 4th or 5th here. So thankfully, we're not seeing a lot of them that we're not having to be so interventionalist with. Often what we'll find, these are particularly people that carry a bit of hip pathology, if they do get a little bit of synthesis pubis pain, that injecting that, sometimes with prolotherapy, sometimes with cortisone has been helpful. I'm aware that injecting the adductor insertion and enthesis, can be used at times. We've just never had to do it. But I completely would consider it if a groin did become problematic.
Thank you. Yeah, that sounds good. The other question I had is, obviously, I live sometimes in different worlds, and UK is very athletic population, and athletic. The physios are very exercise based, and in German speaking, they're more manual based. Is there any manual treatments or active passive treatments you come across who made any difference to you in treatment of these patients?
Yeah, absolutely. I think that when I think about, let's say we take the rehabilitation and we're trying to, if we take, okay, I want that pelvis to get out of anterior tilt into posterior tilt. I think manually the first thing you've got to do is grease that groove, so to speak. You've got to make that easier. You've got to lengthen the things that are short, that are pulling the pelvis in that position. You've got to facilitate manually, you've got to facilitate that movement into posterior tilt so that the patient can then actively do it themselves. You've got to make that path easier. So in terms of probably the two things where you'd be manual would be around pelvic mobility or lumbopelvic mobility. And the second would be around hip mobility. And big tools around that would be, you know, that belt distraction treatment, so any kind of distraction treatment at the hip, where your patient is in supine, you're trying to draw the head of the femur away from the acetabulum, almost trying to decompress the head of the femur within the acetabulum, trying to lengthen the capsule. Tension arcs, which are a new concept coming out of Holland, something we would use here to help try and improve that hip internal rotation. Very aggressive technique, but exceptionally successful, and we employ that a lot. But I think manual, probably I would like to say that I would probably marry both techniques. So our first movement with the players rarely straight into the gym. There'd be time spent on the physio bed, just trying to glide these movements to make. So if I want to do some hip stability work, why don't I unstick the hip first? Maybe I release the adductor longus proximally. Maybe I draw that pelvis out or the head of the femur in the way that I've said. So you've got to make these muscles and joints more accessible to then rehab. But very often, one technique over the other is rarely right. But a good merge of the two is something that we always aim for. Good.
I think, Rory, that's very kind of you to spend your time with me to explain those things. And I think you've gone with us through this quite nicely. And I think a lot of listeners can take some tips out of it. So I thank you for your time, and maybe we will have the chance again to speak about this.
Thanks again for having me on.